Hi everyone, it's Charles from In the Mess, and today we're going to be taking you through another quick flick covering analgesia. Everything that we can tell you that you should know in 2 minutes or less. Quick disclaimer for this one, because we're going to be talking about a lot of drugs, there are an awful lot of nuances to the dosages in very, very small and frail people or larger people, and you need to be aware of things like liver failure, renal failure, and allergies. So as long as we're happy that we need to double check our contraindications, like GI bleeding for non-steroidals for example, then we can use what we're about to share with you as a framework for making a decision and having a go at demystifying some of the things you might see on the ward. When you're treating pain, you're following the WHO pain ladder. So everybody starts with paracetamol, 15 milligrams per kilogram up to 1 gram, 4 times a day, 4 hours apart. On top of that, you can add a non-steroidal if there aren't any contraindications. And this would be something like ibuprofen at 400 milligrams 3 times a day, or diclofenac 50 milligrams 3 times a day. If that's not enough, the next thing you would do is add a weak opiate, and that will be often dihydrocodeine. 30 milligrams, 4 hours apart, 4 times a day. Plus you can have a few more doses PRN. If you find that someone's still sore after that, then you could add a strong opiate to the dihydrocodeine background. So 4 times a day dihydrocodeine, but then oral morphine solution, for example, as the breakthrough, 0.2 to 0.3 milligrams per kilogram, round it to the nearest 5, 10, 15, 20 covers most adults. Now there are some people for whom dihydrocodeine and breakthrough oral morphine isn't enough, and so you would start them on regular strong opiate in the background. You would bin the dihydrocodeine at this point and replace it with morphine sulfate, which is a slow release preparation, or if the patient was using oxycodone, then a long release oxycodone preparation. And this can be anything from 10 milligrams twice a day way up to enormous doses. If you are called to see one of these patients, then a good thing to remember is that your breakthrough dose should be 1/6 of your total daily dose. So if they're on 40 twice a day of MST, that's 80 milligrams, so your breakthrough is 15. Simple sums for the bedside. Now if somebody isn't able to take drugs orally, then you need to give intravenous analgesia. So you can give paracetamol intravenously, and if you are wanting to give opiates intravenously, then you can either get some morphine and bolus it yourself, so get 10 milligrams of morphine in a 10ml syringe and give 1 milligram every 5 minutes till they're comfortable, or you could set up a PCA. Now at all levels of the analgesic ladder you might see some adjuncts, so things like ketamine, which should very much be used with specialist supervision, call your anaesthetist about it. You might see pregabalin or gabapentin. Again, probably best just to leave that be unless it's something that the patient was already on, that you would just continue as normal. And remember the simple stuff, so reassuring people, heat packs and compresses, and immobilizing any fractures will always help with pain. That's a really, really quick summary of a very complex subject, so look out for a deep dive in analgesia coming soon. And as always, don't forget to like this video and subscribe to our channel so you never miss a thing.